All right, welcome everyone to the November Gravity Affinity Group meeting. Hard to believe this is the last one of 2025 already. Give folks just a couple more minutes to join, and then we'll get started with our presentation today. Thanks for joining, everyone.
It
And
might be
maybe,
respectful of those of us who are already here to get started. Thank
yeah,
you.
let's go ahead and get started. All right. Well, welcome everyone. Again, my name is Emery Henderson, and I'm the Grants and Programs Manager at Civitas Networks for Health. So before we get started, just wanted to review some housekeeping items. Here are our antitrust practices for HL7. So Gravity participants have the responsibility to fully comply with federal and state antitrust laws. I won't be going through all of the bullets here, but adherence to these guidelines involve not only avoidance of the antitrust violations, but avoidance of behavior. And then some more housekeeping. This is a Zoom meeting and is being recorded, and the recording will be available on our Confluence page within a few days. So please keep yourself muted if you're not actively speaking to limit distractions. And then feel free to use the raise hand function to chime in if you have any questions or comments. And then also feel free to add your name and organization into the chat as well, so we know who's in the virtual room with us. All right, and here is our agenda for today. I'm really excited. We have a great lineup for you. So we will start with some gravity updates from Corinne Bogan and Sarah DeSilvi, and then we will move into a presentation on the payer perspective and leveraging gravity standards to address value-based care principles by Highmark. And then we will have a member roundtable on ROI from Esther, Elena, Rachel, and Joffer, followed by a Q&A and office hours. And then we will talk next steps as this is our last meeting of 2025. All right, so just quickly, if you're wondering why Civitas is facilitating, I am happy to answer that. So we are an implementation partner with Gravity. And if you're not familiar with Civitas, just a brief overview of what we do. We're a nonprofit mission and member-driven organization, and we're focused on improving health outcomes for all health improvement and health data exchange. So we have a pretty diverse membership from HIEs to RICs, QIOs, among others, taking data-informed multi-stakeholder approaches to health improvement. And then, as I mentioned, we are implementation partners with Gravity. So you can see the three work streams of Gravity Project, with Civitas being nestled in at the bottom as an implementation partner. So as implementation partners, we work closely with Gravity and also provide in-kind support to run the Affinity Group meetings. All right, and then I will hand it off to Sarah and Corinne for some Gravity Project updates.
I'm hijacking just the first topic. Usually Corinne handles these only because, hello everybody, Sarah DeSilva, Gravity Terminology Director. We have a lot to say about terminology, and I was on the call, so we thought I'd just take it. Our consensus vote for our fall domains is today. So for anyone who's participated in that, and I see members and community members on the call today, thank you so much. Our vote commences in just an hour and a half. And the topics were community food access, neighborhood safety, and access to green space. So we see you there. Voting runs through tomorrow at 5 p.m. Pacific time. So if you are not able to attend the meeting but want a absentee ballot, just let us know. We are looking forward to our winter 2026 domains or spring 2026, whichever way you look at it. We'll be addressing legal needs and the two topics: interpersonal safety, child abuse, and abuse of non-elder vulnerable adults. And we do query the community for curriculum vitae for subject matter experts. We do want to make sure that we curate and cultivate the best experts we possibly can for our domain. So if you have experts you are aware of in any of those three domains, please send them to us. And just lastly, an announcement: we did publish our version 1 of the program classification through our enhancement work, and that's available for view. More on that in terminology. And Corinne, over to you.
Sarah. Yeah, if you are planning to attend both meetings today, a lot of content, long day for gravity, but exciting stuff. So on the technical side, we are rounding out the year as well with our last few public calls. We will be doing kind of a report out and ballot prep at our next public call, December 3rd. Again, we are looking to ballot our STU 3.0 IG in January 2026. So this is an important time to engage and submit any last thoughts or comments before the ballot is submitted. And then there, of course, there will be a formal comment period as well. And then if you are not yet engaged and signed up on our listserv, I will throw that link into the chat for everyone. This is where we'll be sharing the results of the consensus voting process, as well as some additional upcoming technical work stream updates. We'll be planning for Connectathon in January soon as well. And so that is the best place to get information across all work streams is from our listserv. All right, and we can go to the next slide. And then we wanted to take this time today, since it is our last quarterly call of the year, to just kind of reflect on our member-led ROI series to date. So we've had 4 quarterly calls that have focused on a number of different topics from different perspectives across the health and social care sectors on return on investment. And we're excited to close out our series with today's on payer perspectives, and then a member roundtable from a few of our members from other areas of this health and social sector. You can see all of these existing presentations, recordings and slides on our Confluence, which I've just added to the chat as well. And then across the rest of our implementation work stream, we've also continued to work deeply with our implementation partners in New York, providing hands-on technical assistance and support in their adoption of the Gravity implementation guide across their Shiny network. And then additionally, we've published member-informed materials and best practices to support early adopters and implementers across the states. And those materials are available on our Confluence as well. So it's been a big year for the implementation work stream, and we're excited to continue to see how it explores and evolves for 2026. And if you're on our listserv, you will certainly be the first to know of what our focus will be next year. Thanks, Emery.
And then we just wanted to take a moment to also highlight some milestones of implementation. We really try to highlight member strategic goals whenever we can. One of the evergreen ones for as members is the goal of widespread adoption and use of Gravity standards. It's there every time. We just want to note collectively that we are seeing across the national and state ecosystem really increasing momentum for implementation of our standards, really enforcing their role in enabling interoperable, actionable social care data documentation exchange, and supporting equitable service delivery. Corinne and Corey and I were doing recon for an upcoming blog, and it was kind of fun to see all the places that it's mentioned. So we know USCDI V3 is incoming. We just saw mention of Gravity standards in the Medicare physician fee schedule. This is the quote: "We recognize the importance of aligning with national standards such as Gravity Project to promote interoperability and reduce implementation burden." So that was nice to see. And then we see increasing state level mentions and implementations. We are writing a blog about this for HL7, and the NCQA social needs measure stays intact. So regarding implementation workstream, that's kind of fun stuff to report at the end of the year. And now we go to the rest of the show. Demery. Welcoming our friends. Oh, sorry. You want to lead these, Corinne, or I can? Whatever. I'll go for it. So member grant opportunity. We try to do new announcements. American Medical Association has a community health impact lab micro grant program is available. Supporting physician-led initiatives aimed at improving health outcomes at the community level. We want to just make sure members are aware. The link will be in the chat, and grants, they're up to 20 grants, about 50,000 per recipient. And we want AMA as a member, we're very appreciative of them and wanted to highlight this opportunity. And then the next slide is another member-related initiative. Next slide. Ahima, who actually collaborated with us on the documentation of social needs paper that Corinne mentioned as part of our 2025 resources, also has a white paper out for public comment called Building Patient Trust in the Collection, Use, and Sharing of SDOH Data. It seems incredibly relevant for our work in implementation and Gravity. And there's a period of comment through January 16th, and we look forward to, we're glad to share it, grateful for Ahima's expertise and our internal resources and on our project, and want to make sure all of you all who care deeply about this topic can comment on the proposed draft. Okay, and now I think we're done with announcements. There we go.
Perfect. Well, I would like to welcome our friends over at Highmark for their presentation today. I know we have Amy on the line, and I think she's going to kick us off.
Awesome. Well, thank you all for having us today. We're excited to share some of the work that we're doing at Highmark. My name is Amy Shannon. I am one of the directors with the Enterprise Social Determinants of Health team. I've been with Highmark for a little over 20 years, and by background, I'm a social worker, so this is near and dear to my heart for the long term. With me today are my colleagues Maggie Shano and Elizabeth Giel, and I'll let them introduce themselves. So go ahead, Maggie.
Good afternoon, everyone. I am Maggie Shano. I'm also one of the directors on the Enterprise SDOH team. I have been with Highmark for 7 years, not quite as long as Amy. And this is my first time in social determinants of health, but I am certainly not new to the concept.
And Liz,
thank you. Yes, good afternoon, everyone. Liz Giel. Joined Highmark actually just back in April. I'm a pharmacist by background, coming over from CVS, so coming over to our product management team at Highmark Health. So part of my portfolio in provider interoperability includes Epic Payer Platform. So we're going to walk you through some SDOH capabilities that we have live today within EPP. Thanks.
Awesome. So we'll kick it off. If you don't mind jumping to that next slide, I want to just make sure we have a little foundation first of who is Highmark Health. And as you see it noted here, very quickly, we're the fourth largest Blue Cross Blue Shield affiliated organization, and Highmark Inc. and its affiliates support over 7 million members. And what that really means when you click into that, we can look on the next page. If you want to jump to the next one. What you see here is Highmark Health is the parent company of Highmark Inc., who's the plan, as well as our Medicaid plans through Highmark Health Options, Allegheny Health Network, who is our blended health organization, and then Highmark Health Solutions and all the entities that you see here in the bubbles. It really brings together a very diverse portfolio of business to serve our customers and communities, and we employ more than 35,000 people, serving members that we have across all 50 states. The Inc. part of our plan and our Medicaid plans cover a little over 5 million members in PA, Delaware, and New York and West Virginia, as we saw on that map previously. And so this opportunity, all of these entities really align for us around one mission, and that's creating a remarkable health experience to free people to be their best. And so in order to achieve this, we committed to what we call our living health model that encompasses supporting our members' physical, behavioral, and social health. And that component of social health is really what led us to engage with Gravity almost 8 years ago now. So it's been some time, so we appreciate the partnership. And so as you go, probably you can go down actually 2 slides, you can go one more. So from that social health journey, the first step was to create a tool that would be leveraged across all of those enterprise partners that we just looked at. Create a tool that could be used to assess our members' social health status. And you see on the majority of the left side of the page, the 9 core domains that we aligned on that we assess for: financial stability, social connections and employment, housing stability, food insecurity and transportation, health literacy, safety, and then access and affordability as it's reflective of childcare, healthcare, clothing, and digital access are really the areas that we focus on in totality across all of the enterprise. We sourced the questions from the validated tools, and we established a process to ensure that the enterprise, that we asked the questions consistently that enabled the data capture and comparability. And then, as noted, they really support the regulatory requirements that have been presented to us over the past several years, whether it's through CMS or NCQA and others. We also have some supplemental domains here that you see on the right-hand side that we do address as well. This assessment tool, as you see on the next slide, if you don't mind clicking down one more, what you see here is where we've enabled the member to access this social health assessment. And we've placed it in many areas through omni-channel access points so that it really supports the members in answering in a time and a location where they feel most comfortable or most supported to speak about some of these sensitive issues. What you'll see here is our AHN colleagues ask the question, really robustly throughout their full provider facilities and their ED, inpatient, outpatient, primary care. They have it in my chart and through e-registration. We have it in our health plan clinical platforms and in HRAs, as well as we have it embedded with some pharmacy partners and vendors, as well as digital marketing campaigns. As we implemented the assessments, we followed with adding the screening codes that you see here, indicating with the green outline that's where we've tied the associated link codes. And in the dark blue, we've also included the Z codes and G codes. And so all of which are aligned with the Gravity standards. And obviously, you'll see there on the left that we're still working through those access points, getting the codes linked from our internal sources to the screening components. The next slide really shares information around where we're actually partnering with our external vendors who oftentimes don't use the same assessments that we do. And so we've taken their assessments and partnered with them to help them identify the technology that's needed to link their codes so that we can use it not only for our reporting and our analysis, but also for our compliance. And so what you see here is some of the work is complete with some of our partners with Amwell and Concerto Care and Unite Us, and we're still working on it with other anchor partners that are non-Epic. And you'll hear Liz talk about the work that's happening with our Epic partners. With
Amy,
the access, yes.
What are Concerto Care and Amwell?
Oh, thank you for asking, Lucy.
Thank
Amwell
you.
is a virtual primary care partner so that it enables our members to engage in primary care through digital connections and not through brick and mortar facilities. Concerto Care is a vendor partner that we have up in the New York area that actually does home visiting with a specialized population to ensure that they've got the supports and services that they need in the home, as well as both clinically, socially, and behaviorally. They provide those supports. Thank you for asking the question, Lucy. On the next slide, what you'll see is how this assessment process is going. Obviously, we didn't implement all of those access points at one time. They've grown over time, and you can clearly see the increase in that over time. To date, we have over 3 million assessments conducted with our Highmark and AHN patients, with that growth showing year over year. And we're working on coding out those interventions so that we can get that further down that member journey. Those interventions, that coding work, you can see on the next slide. Where we are capturing it and where it's in development is these 8 access points with the purple outlines to them. We have either coded or are in the process of adding the SNOMED codes, which will then again allow us to analyze the data for what referrals have been made. And then the next step will be making sure that we have the right documentation and infrastructure that allows us to show the end-to-end journey of that screening. These are the interventions moving into what does that closed loop really look like. This data, gaining the data, having that interaction with our members and our patients has really been critical in supporting them and then also creating then the social care network that helps provide these interventions. And so I'm going to actually hand it over to Maggie at this point to share with you what that social care network is and how it's really benefited our members. Maggie?
Awesome. Thank you. Thank you, Amy. Let's go to the next slide. And the next one. All right, cool. So the Social Care Network, it started off as a grant pilot. The Richard King Mellon funded this initiative for 3 years, so we were able to build everything from scratch. And there were several goals for the Richard King Mellon Foundation. The first one was demonstrating the value of CBO's work. I think we as organizations kind of suspected all of the great work that CBOs did, but this was really a way to quantify that work for funders, et cetera. The second one is around customer experience, improving patient engagement and caregiver satisfaction. Prior to having a network like this, if a member screened positive, just as Amy mentioned, if a patient screened positive, there wasn't, and this ties into number 3, which is a solution for clinicians, is the clinicians were in some ways hesitant to ask some of those questions because if the patient screened positive, they didn't have a formal way to make a referral to a solution, or they didn't have a trusted solution that they could refer to. And so this was really trying to tie those two arms together. The fourth one is around healthy communities, so improving access to social services for the community. I think a lot of people in the community are not aware of all of the various opportunities that are available to them, whether it is through a food bank, whether it is through one of our community action councils. So this was also to bring awareness for the community. The fifth one is around scalability. So we as Highmark, we wanted to take this as a test and learn to see if we could take these findings and scale it to other markets. And lastly, I would say probably most importantly, especially for funders, is funders are tapped on the shoulder a lot for funds and support. And funders needed a way to measure impact and say which organizations are really making a difference. So this program aimed to do that as well. Next slide. All right, so how does it work? So Amy talked about all of those wonderful access points. There's over 20 of them. When a patient or a member screens for an SDOH need, that information is then routed to our social worker team. The social worker team would reach out to the patient or the member. And if the patient or member consents to being referred to one of our in-network CBOs, then they will make the referral using the Find Help platform. Once they make the referral to our CBO partners will pick up that referral and they will outreach to the member many times over a course of 3 to 4 weeks and try to establish contact and try to work with that person to address their SDOH need. When they address it, they will update the Find Help platform to let us know what happened. And then after a time period, we monitor that in Tableau, and we compensate the CBO for their assistance. So end to end, that's how the program works. Next slide, please. So you may be wondering, what are the outcomes? Pilot program, it was a 3-year pilot. We took the first year to really build some of the foundation. So from a data perspective, we have nearly 2 full years of data. We helped to engage about 2,800 lives. And as you can see in the upper left-hand quadrant, 1,700 of them we're assuming community members because we were able to match nearly 1,200 back to a Highmark member. Those Highmark members are anything from the commercial segment to Medicaid to the Affordable Care Act, as well as there's one more that I'm missing. I'm trying to think of my graph.
Med Advantage, probably, Maggie?
Yes, thank you. Yes, Medicare Advantage. Yes. So those were like the 4 primary lines of businesses that we saw utilize the network. And then in the next kind of set of charts in the donuts, you'll notice that 95% of those referrals ended up in a closed loop. So closed loop is letting us know what happened with that referral. Now, the remaining 5% does not mean that they were not closed. That remaining 5% actually means that they're open, like actively working on those referrals. So in like true technicality, we actually get 100% closed loop. And then on the right-hand side, compared to the out of network, that should, I think it's like 24% or something like that, where 24% or so of the out of network CBOs use that Find Help platform to let people know what happened to that referral. So by comparison, I would say the in-network CBOs really crushed it as far as using the platform to let us know what happened, what is happening closed, and what is other blurry definition. Not sure what Heidi was asking. Heidi,
So
did you?
on
Yeah.
your graphs
Yep.
here, you've
Yep.
got clearly closed, and I think you just described it,
Yep.
but it's like there's two boxes of text on top of each other there, so it's closed and not
Not closed.
closed.
Yep. Yep.
Okay,
Yep.
thanks.
Yep. Cool. So the top 3 referred SDOH domains was financial resource strain, food insecurity, and transportation. Financial resource strain is primarily utility assistance. That's really the thing that we see most. In the middle there, you can see that the program was highly well received by our CBO partners as well as the referral makers, and majority of the users were female. Next slide. All right, so some results. What did it look like? It's broken out by commercial Medicare Advantage on the left and Medicaid on the right. The high level takeaway is we did see overall lower medical and prescription cost savings, lower spend in medical and prescription costs for both populations. But what's actually really interesting is if you focus in on the commercial and Medicare Advantage area where it says RX only, you'll see that that teal bar is slightly larger than the yellow bar. So our interpretation of that is that the folks who have gotten help through the network, which is the teal bar, they're actually like filling their scripts more. So we look at that as really awesome news because of med adherence. Yes, a good thing for sure, Sarah. So that's really what we like to highlight on this slide. But overall, in general, for all of these lines of businesses, we did see savings, medical cost reduction, primarily in the ED avoidance. Next slide. All right. So one of the things, if you guys, Google this on Google and you look for high performing social care network, that is how the pilot program was coined. It was high performing social care network. One of the things that we were tasked with was, well, what does high performing mean? How do you measure that? So the team over the past, that pilot program, like 2 years or so, we continued to iterate on that model. They really looked at those 2 things that you see on the axes, network efficiency and overall performance. So it's really trying to take those CBOs to say, based on a particular SDOH domain or service type, how did one particular CBO perform compared to their peers? And there was just a whole bunch of other things that go into these factors. But in general, we were able to map our truly high performing CBOs compared to some of the other ones that just didn't meet some of our SLAs, if you will. So this is something that I would say I'm really proud of the team for creating. This is something that our funders are very interested in. And yeah, that's really our interpretation of a high performing CBO. That might be my last slide. Yeah, cool. Any questions? Crushed it. Awesome.
I have
Thanks.
to,
Yes.
Maggie,
Yes.
I'm sorry, I always have a
Okay.
question.
Please.
Slide 22, where you provide resources to a provider who has discovered a need. Number 3.
Yeah.
The network provided clinicians with a curated network.
Yep.
Is that through United, or does Highmark actually have all these resources by zip code or by something?
Yeah, so for the pilot
How does
program,
that work?
so for the pilot program, because we were grant funded, it was for 2 counties, Allegheny and Westmoreland County here in Pittsburgh, Pennsylvania. And so what ended up happening is we contracted with various nonprofits. It was a total of 37 at the peak of the pilot that really addressed all the various social health domains that Amy covered in her previous slide. And so what ended up happening prior to having a network like this is each individual practice, if you will, would have a manual notebook, if you will, and they would say, okay, I trust this person. I've referred to them before, they're reliable. But that's just one practice, right? Other practices may not have those same resources. So this program really formalized in some ways that digital communication, because once they log into Find Help, if you will, we on our platform, there was a way that we were denoting which ones were part of our in-network CBOs. So as the referral maker logs into Find Help, they would type in the zip code, and then whatever the SDOH domain is, let's say that it's food, type in my zip code, I see that it's food, I need some food pantry assistance. The stuff that comes up to the top are the in-network CBOs, and there's a label that indicates who they are. And that's how we were able to provide our networks or our provider network with this resource. We also provided training to the provider resources so that they were aware that this social care network is available to them. Does that
Thank you
help?
for that detail. Yes,
Cool.
definitely. How does this scale then? How do you
Yeah.
scale this? You
Yeah.
serve a lot of people over a huge geographic area.
Yeah, I mean, scaling is something that we are working on now. One of the advantages that we have here in Western PA is Highmark and AHN, the health system. We are a family, right? So a lot of that information was, it's really easy for us to send referrals into the Highmark family network, if you will. Once we go outside of AHN, we're starting to explore some of those interoperability options to really expand there. But right now we are in West Virginia, so it's from a accessibility perspective, it's really by case management or social worker referring into the network. And then, of course, if we have an AHN facility, they can also refer into the network. So we are currently solving for outside of AHN.
Thank you. I think that's a key system characteristic that often comes up. It's all
Yeah,
very well to talk about referrals, but how do you actually find where a person really can get help and wants to go? So
yeah,
thank you.
yep. Kathleen.
Hi, this is really fascinating pilot here. Do you think that maybe something like this could be done in like larger hospital systems who are wanting to be reimbursed by insurances for more of their SDOH work and food insecurity work?
That might be coupled for Amy since she's working with those codes.
Yeah, I think it's a twofold conversation in that respect. I think that as we think about how value-based reimbursement, pay for performance, those elements will come into play. I think there's a future opportunity for some reimbursement in those areas. That's not where we are right now, but I think that's in the future space. And then I think the continuation of the social care network reimbursing CBOs for the supports that they're providing. So, two different areas of it, the screening and then actually doing the resourcing. So I think that that's in the future.
Thank you.
Yeah. And I think Heidi, you had a question in the chat too.
Yeah, it kind of builds on that, Amy. Just wondering if you could speak a little bit more to any potential contracting or reimbursement processes, maybe ranges of reimbursement. Like, how did y'all approach that? I know these are questions definitely facing our region. And
I'll
I'm
hand it back to Maggie for that one.
There
Okay.
are criteria that a CBO must meet before we approach them. We have a three-part methodology that evaluates whether or not we will bring a CBO into the network. As far as the reimbursement goes, we iterated on this at least 3 times. So there was one reimbursement model when the team launched it. And then as we started to have lessons learned throughout the way, we modified the reimbursement compensation schedule, if you will. It ranges depending on what the services are. And so, we wanted to make sure. So for example, helping someone address a food insecurity is going to be a lot cheaper than helping someone with rent or utility assistance, right? So we wanted to make sure that whenever we compensated the CBOs, that it was kind of equitable in that way, and that we weren't applying a standard fee, right? Because we wanted to account for some of those nuances. So we iterated on that 3 times. How do CBOs send the closed loop responsive confirmations? They use the Find Help platform. So for the inbound, there is just, they have a drop down and they would just simply go in and update the drop down to let us know what happened. And then on our end, especially with like the case management system that we have, which is called Predictal, if there's a button in Predictal where we had the integration with Find Help and Predictal, there's a button that like says get update or something. So the case manager or social worker would actually go into Predictal, hit that button, and then whenever the CBO has made that update, that information is fed back into our system. Does that help, Heidi?
It does. One clarifying question. I'm hearing you say case management, and one of the questions that's really starting to come up in our region is the difference between a closed loop referral and case management. Did you also address that?
I'm not terribly familiar with case management side. Amy, I don't know if you want to.
Yeah, Heidi, we might have to click into that a little bit more because from how our system works, case management, and it could be a nurse or it could be a social worker will make that referral through the Find Help platform to that CBO within our network. The CBO, as Maggie describes, like our closed loop that we do incentives for is when they identify that the member has gotten help. That's the closed loop there. So as Maggie describes, if they push the button and there's no update yet, the case management team can reach back out to that member and be like, hey, Verge of the food bank, any issues going on? I don't see that you've gotten help. Oh, I haven't been able to go, or I lost my transportation. Then they can work through those issues. They can make re-referrals, they can do additional pieces, but the closed loop is specific to the CBO. And then the case management does the additional coaching, referring, and those pieces. Does that get to your question, Heidi?
Yeah, that's helpful. Yeah, I'll stop there in the interest of time. I know there's more.
I know we got to let Liz jump in here, so too. So yeah, Sarah, you called it out. If we want to let Liz share her exciting insights, that would be probably for best. And we're happy to have conversations again later as needed.
All right, thanks. We can move on to the next slide. And I realized as putting this materials together, some of you might not know what is EPP or Epic Payer Platform. So I'm going to just start there at a high level too, and just, walk you through a little bit more about our Highmark provider footprint too. So sitting on the health plan side, our provider footprint is Epic wise is a makeup of about 40 to 50% of our current providers. That is growing for us. So, upwards of reaching closer to 60 to 70% over the next year and a half. So with that said, the Epic EMR allows us to bidirectionally exchange data with our providers that we connect to through EPP. So of those 40 to 50%, we have a portion of those that we are continuing to connect through the payer platform services and continuing to scan our provider pipeline in that way. So through this capability and that bi-directional exchange of data, that allows us to just service our members and focus on either providing those clinical insights out to our providers or getting those insights back into us. That can include data insights in the risk adjustment space, in the care gaps and quality space, as well as what we're talking about here, which is SDOH data as well. So then that allows us to continue to provide better collectively between ourselves and our providers, better care to our members. And through this exchange of this SDOH data here, so walking you through this process, so we have currently live providers here on the left-hand side. We've only had one provider so far disagree to or decline to exchanging some of this data, but for generally majority of our population here, allowing that data then to be shared as a CCD, and then processed through our internal data engine to then be processed and converted into an EMRN file. So that data is then captured, mapped into an EMRN file, and then sent to our HEDIS team. So that will then enable us to close our what we're calling SNSE gaps, or SDOH measures that cover housing, food, and transportation needs. So we're sharing all of these, data insights, getting this data back, and then being able to essentially close those care gaps faster, and require a lot less manual intervention for some of this great care here. So that reduces dependency on us having to wait for claims, any sort of claims processing limitations, any coding, manual coding work that either goes wrong or takes too long on the background. A lot of this data exchange is then happening in more near real time, and it's just more transparent and seamless. So allowing us to have better knowledge about our members and these insights to essentially impact, compliance in this space and have a more comprehensive outlook on their care. Any questions on how currently this process and this data exchange is working for us today?
Could you explain how the member consents to sharing this data? Is that part of the intake when they're first presented with these surveys, either remotely or in person? Do they consent to all of this in some form explicitly, not just as part of, yes, you can do whatever is needed?
Yeah, good question. Through some of in being less close to this on the provider side, providers do have those consent to treat or consent forms that they manage per provider location. So they are helping us manage some of those member rosters or which members are opting in and opting out of some of this data exchange. So yes, essentially there is not necessarily explicitly from the member, but on the background, there's always security checks, member HIPAA compliance, PHI data exchange, and security checks there on the background happening about these members.
And Liz, if I can add to that, if you don't mind, Lucy, you mentioned like when the members engage with the survey itself. So where, I was showing that wheel of access points, the member makes a conscious decision to answer those questions, and they can give consent whether or not they want to be engaged with if they screen positive, with whether it be social worker or the clinicians and so forth. Our assessment is a voluntary assessment, and then they have to consent, as Maggie said, to have referrals made to the CBOs. And then, as Liz said, they follow the HIPAA guidelines.
And have you found that members understand this? I mean, one of the things that often comes up is the level of literacy about what SDOH issues may be and how I may be treated or affected if I consent to all of this. How have you dealt with member education about why they should do this?
So from the standpoint of when our social work team or nurses or our HN partners engage with the member or the patient, their training around motivational interviewing and sharing with them the why it matters. We have done a lot of work around that education to help them then communicate to the members that this matters. This affects their health often more than, their ability to be in a doctor's office for, 30 minutes at that time. That what happens in their everyday life is very impactful. And as I think everyone on this call knows, the food you eat, your access to care, the condition of your housing and neighborhood, all of that affects. So we take the time to, when members express those concerns, take the time to educate that, take the time to let them know that others experiencing these issues can get access to resources. There is help out there, and that we have posters and things in our HN areas that says we ask everyone. It's about everybody can experience these challenges at any given time. And so we try to walk through that and then also share that living health model that we really believe all three components are essential to know and support and treat.
And I did see Robert's question in the chat here too. We do, from a Highmark standpoint, definitely we control this for sure too. A lot of the way, Epic, of course, has their own controls that we abide by from both a payer side and then also a provider side as well too. So close connection with Epic, but on the Highmark side, we have data governance committees, constant, government governance forums where we're taking some of these data, these new capabilities or this new data offerings and bidirectional exchange of data to those committees to be sure that they're vetted and properly. Kathleen?
Yeah, so do I understand correctly that it sounds like you're reimbursing CBOs based on the data that you're getting from users, from patients, and not so much billing? Is that right?
Amy, do you want to?
Yeah, it's so what ends up happening is when the CBO uses the Find Out platform and chooses that dropdown that says, God help, for instance, on our end, those are the things that we measure and we track. We also do some reconciliation based on some reports that we pull directly from Find Help just to make sure that the folks aren't over-reporting. But no, there's no billing. We track it on our end. We're able to see how many referrals are sent to a particular CBO that is in our network. And then we reconcile that and we pay the CBOs. We just cut them a check. There's no billing. It's actually very easy for the CBOs, and they love that because, who doesn't want to not do administrative work? So yeah, it's been great for them.
So within this whole process, is there any is anybody using the new Medicare or Medicaid the CHI billing codes? And if so, like how are those being utilized? Because I know that the patient has to see a provider first. And so how does that work when it comes to community health workers? Because not a lot of hospitals or healthcare systems have community health workers, and then CBOs have the health workers, but they don't have the physicians. So I was just looking at these codes and I'm like, how are these being reimbursed in this environment?
So I think your question is about CHW reimbursement, and this is not reimbursing CHWs. This is about community-based organizations, and so it's specifically reimbursing them for their support services. They may use CHWs. That's not the billing process for this program at this time. And for Epic, it's an exchange of data. And I think I know, Liz, you have another slide to get to, so I want to make sure we get there as well. But yes, the CHWs can be reimbursed under provider supervision. We have CHWs in various parts of our agency, parts of our plan, and part of our payer net or provider network, but they are not at this point incorporated in here as a CHW.
Thank you.
Yep. Do you want to jump to your next slide, Liz, if you're ready?
Sure, we can. And while we do that, one more question came up from Robert in the chat. Thanks, Robert. So question was around fire and the use of gravity IG. I would active discussions with Epic to continue to influence them to move towards some of these more new standards. And I will add to, especially for those on the call that may not be, within an Epic footprint or live necessarily with Epic, we're continuing to explore and proceed down similar pathways with other EMR. So those, like Athena, the Cerners, the Vertigime, so other solutions that offer some of the EMRs that offer some of these same capabilities. Several of those, are adopting and moving towards some of those fire and IG based standardized approaches. So pretty excited about that. And it is part of, I would say collectively across our organization, part of our organization strategy in the interoperability space. And we also have several other fire capabilities homegrown within our organization that we're moving towards that is doing a lot of the same thing and helping instill some of these feedback loops and enabling some of the, that feedback between us and our providers. All right. So, and where do we head next to? And I'm not going to spend detail walking through each one of, what's on our roadmap here within the EPP space, but essentially, at a high level here, what are we going to do with this data? How can we utilize this and almost turn this into some use cases internally across both, Amy's team and Maggie's team, who we partner with in the SDOH space. So thinking through, how do we use some of this data to better inform some of our reporting, our dashboards, our Tableau dashboards, and then inform some of our program design. So now, of course, thinking we're getting more robust data coming in. What can we do with it? How can we utilize that? How can we think more creatively or outside of the box or think differently about some of these new data insights that we're getting? So continuing to work through some of the, like some program design work across the team. Also, adding, there are some features that some of these payer platform solutions offer, EPP in this case, being one of those through the health plan clinical summary. So utilizing that health plan clinical summary to send this identified data out to providers too. So allowing providers not only to send that data to us, but for them to uncover and see data that we might find out as a health plan too. So presenting that data to our providers so that they could provide better real-time care to patients within that appointment. We also have a use case to update social workers in that data as well to allow, as Amy and Maggie were talking through earlier, our Predictal platform. So in our care management space, bringing that data in and then enabling our care managers to have better point or interaction points with our members too. So utilizing these data insights to then enable or provide better action or operationalize some of that with our case management teams. And then finally, we're continuing to build a member longitudinal record and just continuing to maintain that record for that member and ensure that all of our data sources or those endpoints have the right data about the member and the same data about the member at all times too. So continuing to utilize, this data coming in to be sure that not only do we have a rich and robust data insights about the member, but also that it's very consistent across the experience to drive that frictionless experience too. So a few more additional use cases here on the slide, but we'll pause there just 10 minutes here in case anyone has any final questions for our team. And thank you.
I think Elena had a question in the chat. It's up a little bit now, but how do you account for service capacity, and are CBOs getting paid for accepting referrals in the network separate from the cost of providing the service?
So if the CBO is at capacity, that's an easier one. If the CBO is at capacity, one of the things that we work with them on is my team members have regular touch points with them. And if they are reaching capacity, then we simply shut that card off so that they're not accepting new referrals, because we don't want to inundate the CBOs. In that case, let's say that it's a food pantry. Let's say if we shut that off, then the next time someone goes in to look for a food pantry provider, they'll just have to choose the next one that's available. So that's how we've addressed the capacity for now. As far as the compensation, it is a nuanced compensation model, but it's really based on, call it, volume.
Thank you. Okay.
So when you say volume, that's not just acceptances, but actually provision of services. This is a key distinction, at least from a payer point of view.
Yeah,
Are
I
you
mean, I don't know if any other payers are paying for these types of referrals.
But if I accept a patient, do I get paid for that before they are actually in contact with my facility or my agency or my
Nope.
program?
Nope. We only pay on outcomes, so the things that we see.
So I guess
Very
like to
important. Thank you.
Lucy's point, I guess that poses the question of like the the kind of bearing the administrative risk, creating new intake pathways or kind of care coordination pathways. How do like smaller organizations kind of manage that, or organizations that don't have the ability to kind of bear that administrative cost without the outcome side of that payment?
Yeah, as I said, we have iterated on this model 3 times, and I expect that we will continue to iterate on it.
Yeah, and
So
I
it
think
would be fair to
Elena,
say that this hasn't been solved. You're constantly learning,
Yes.
and
For sure.
trying to
Yes.
ensure that services are provided and that people providing the services are compensated adequately.
Yes.
Thank you.
Yes.
and I think Elena, to your question too, is Maggie's team is incredible at that human contact. Like they go out and they meet with the CBOs because, as you all know, one CBO is one CBO. And so when there is a technical challenge or any of those pieces, they try to work with each CBO individually to identify how to make this work for them when they've been part of the, if they've obviously, Maggie said there's lots of threshold tiers of being able to be in the network to begin with. And once in, then they provide that level of support to say, how do we help you get, continue to see success?
That's helpful. And I don't think like to Lucy's point, I don't think anyone entity is even in the position to solve this wider, bigger issue that we all know is a driving
Yeah.
reality of that. If we're trying to create this kind of connection to and access points to all these different service providers, recognizing that they are not funded or designed to take that kind of proactive approach. That's like part of, I think, a lot of the work and tension that we're all interacting with. So I understand that that's like not just a solvable thing, because a lot of everyone's in that space in a lot of ways.
Great. Thank you. I know we've had some great discussion and I see a couple more hands up. If we want to put the questions in the chat, Highmark might be able to answer them in the chat, but I want to make sure we have an ample time for the roundtable. So we will move on. I'll hand it over to Sarah, and then if we have questions in the chat, Highmark can feel free to answer them there. But I will turn it over to Sarah for the roundtable now.
I just want to say thank you to Highmark again before we go. And it's interesting because our second question, Maggie and Elena, is on what needs to happen to make all of this work more seamless. So I think your learning there and expertise there is deeply appreciated and just like so grateful. Again, I noted it early, but Highmark is a founding member of Gravity. That means they've been here like from the beginning, right? And they have been consistent in their dedication to the collective mission. And we are so grateful for them. And really like a great way to cap November in an implementation that really leverages our terminology and actually involves many of our other partners too, which is super fun. So classically in implementation Affinity, we have two presentations. So we thought we'd cap, thank you, 2025 in Affinity by just a little member roundtable, kind of capping some topics in ROI. We can have those members come show your faces. We have two CBO representatives, Esther and Elena, who are, again, as members, they're part of our governance, they're driving strategy, they're involved in building use cases. And we also have representatives from Find Help and Unite. It's very apropos because they were just mentioned in the Highmark presentation. So Rachel and Jaffer, please come and show your lovely faces. Just so I think you might be, hi Esther, hi Rachel, hi Jaffer. I know I was pinging you guys. I was like, here it is. This is the greatest assemblage of all time. Okay, so next slide. So again, two community-based organizations represented today that are part of our governance, and then Unite Us and Find Help, who are also very deeply involved in our work. And these are their words, so I'm going to say them, but they're not mine. I mean, part of my job as a Gravity Terminology Director is to respond to members' goals and dreams and hopes and wishes and make things happen for them. But before we close out this year, I kind of wanted to refresh why we are talking about ROI in 2025. Why is this the goal for 2025? And it's really because of members' strategic mission and how we all, as like an operating group, the PMO, how we operate it and try to execute it in approved things in our work stream. So for two cycles running now, strategic goals. Members have said very clearly that they feel like it's really critical to accelerate data standard solutions to address the payment and reporting needs of those performing health-related social needs service provision toward increasing efficiency, consistent reimbursement, and measurable outcomes, leveraging HL7 FHIR in conjunction with other standards as needed. So we just heard themes about that, pain points, opportunities in the past Highmark presentations, success stories. And then members also led something called the Payment and Reporting Discovery. That was actually co-led by Lena and our friend Emily, who is on maternity leave right now from Unite Us. And the two outcomes that were identified from that work were terminology to support CBO payment and reporting, and continued implementation discovery for service documentation and claim submission remittance activities, right? Trying to figure out how to solve the getting paid for your services problem, right? That Maggie and Elena and Highmark were just talking about. Very apropos. I just wanted to remind us all about, as a community, about those two themes, those two really evergreen themes that came out that members continue to prioritize and we continue to work on in our work. And now we're going to go to some questions. Next slide. Anything else to say, members, on those two things? That's your stuff. It's your expertise. I guess not. So I'm going to now ask questions of members, and I'm going to start with Esther. Esther, my lovely friend Esther. So we have two questions we're going to be focusing in our roundtable, and I'm just going to go through all of you, right? So the first question is, Esther, what in your experience is one salient example of addressing social needs leading to improved outcomes and decreased cost, ideally leveraging Gravity standards? But we had a lovely conversation in prep. So you're a community-based organization, say who you are, where you practice, and what your story is.
Great. Thank you, Sarah. Thanks for having me. Esther Safiliad, I'm the Vice President of Care Management Services at Partners in Care Foundation. We are a community-based organization located in California, but we are also what is called a community care hub. We heard them called as a social care network in the presentation earlier in California. So we have CBOs working through us as their hub in contracts with different types of payers, health systems, health plans, medical groups, you name it. This is close to a lot of the work we do, right? Like, what are some, I was trying to think of examples. And one example that really comes to mind, especially when I think of ROI and I think of addressing social needs and thinking about leveraging the gravity standards, right? It's around reduction in readmissions. In a lot of our health system, hospital partnerships, the focus is reduction in readmission, which in turn, as we all know, right, what does reduction in readmission do? Cost savings, aka ROI, for the hospitals. They save on penalties because we're reducing their readmission. But even more so, another big factor, it may not be a financial ROI, is patient satisfaction, right? There's a lot of them are looking at quality measures and scores and how they're doing. So as a CBO and a network of CBOs that we have providing these services is addressing the social care needs of the patients we're serving, right? A lot of patients leaving hospitals are returning home, have no clue what they need to do, right? They have their discharge instructions. Um, they know they might be able to see their doctor. The doctor says, "I'll see you in 30 days." But we know cause of readmissions. You need to see the patient immediately post-discharge. So how do we leverage all those components with getting the PCP to actually make the appointment with us for the patient early within 7 days? Assessing food. They might have been in the hospital, right? And they're returning home. They have no, some utilities may be off, refrigerator not working, food is spoiled. We need to get them situated with food, transportation to go to that PCP appointment that we're helping them schedule, right? There's a lot of those components as their quarterbacks is what I call ourselves is really getting the understanding the individual needs of the patients, especially in this example, leaving the hospital, identifying what those gaps are, using platforms like Find Help, which our teams use regularly, right, to identify services in their own communities, and then connecting those patients, either hands-on, right? Some need more hands-on connections. Goes back to the care management examples that we were talking about. Or some may just be more doers and just giving them those resources and tools to be able to run themselves. So is then all the outcomes are based on did we help prevent a readmission, avoidable readmission, and then did we get the patient satisfied with their transitions plan, which helps, again, impact all those other components of we may not always think of as an ROI.
I love that, Esther. Thank you. You gave me a little purr last time, but that's even better. So I'm just going to keep on going. Thank you so much. We'll come back and just maybe you all can even talk to each other. Joffer, can you give me a salient example in your experience, of course, find help friend, about addressing social needs with leveraging gravity standards leading to improved outcomes and decreased cost?
Yeah, absolutely.
Ready?
So first, congratulations to Highmark and their
I know.
incredible presentation. Really, really applaud the work they've been doing over the years, Steady and Shirley. Um, Second, we really see ROI in three frameworks. One is really operational efficiency, and that is reducing clicks, building the integrations, reducing the navigation time, reducing double documentation. Whether it's Geisinger or Highmark or many, many others have found significant savings with their staff. And I think we skip over that ROI oftentimes. And we shouldn't. We should recognize the time savings for our staff that are very possible. Also, with coding of this work, that helps us better stratify which navigators should a certain person be allocated to. And that also reduces time so that we're not putting someone in this navigator's queue and then realizing they're, a chronic disease patient and putting them back in some other queue. So that stratification is helpful. The second is certainly the clinical and quality outcomes. And Highmark did a great job of explaining a lot of the LOINC coding and SNOMED coding that's possible, with a lot of platforms today. One example I'll just share, New York H&H. So they've actually screened over 120,000 patients this year. And with 0 clicks, every patient, based on codes associated with those needs, gets curative recommendations on their after visit summary as they walk out the door or even as they're in the acute care setting. And that time savings is enormous. And the codes allow for better determination of the right recommendation. They also are using codes and have about an 86% closed loop rate, so a little behind Highmark, but we're estimating about 8,000 hours saved on navigation time, which is pretty cool.
Wow.
Trinity Health, I think, is another great example. They're in about 22 states. They've been doing this since 2019, and they've had a 15% overall reduction in preventable hospitalizations and about 41% reduction for duals. And that's also really doing great work with LOINC coding and being able to track these hospitalizations as well. And then the social care networks in New York that several vendors are involved in. We're up to about 100,000 plus members screened and about 6 million in reimbursements through HCPCS codes and LOINC code tracking. So it's really exciting that we're having more of these success stories, and I think we're up to 200 trusted networks across the country, and a growing number are starting to add the Gravity codes into those networks. So really exciting, and thanks for the opportunity, Sarah, to share some of those.
Jeffrey, thank you for all of your support and membership and expertise. I'm going to go alternating CBO to platform. Lena, what's your experience and one salient example? Again, all of these folks are Gravity members.
Yeah.
That means they come to meetings, they put in the time, they drive the work we do. So grateful. So Lena, you go.
Yeah, I am, I'm Elena Kalinowski. I'm with San Diego CIE, 211. I'm coming from a CBO perspective of how are we linking all of our hubs of care and to facilitate care coordination kind of in every kind of use case and with every kind of, directionality of how people are getting connected. I just put into the chat what I think is a really very nice, tangible summary on some ROI on like what it means to enable care coordination in a coordinated way, but really where interoperability enables that coordination and facilitates that meaningful connection. And I think like to me, in my work that I'm doing as from an interoperability lens of a CIE linking to hubs of data and hubs of care. Gravity Standards is continuously creating language that we all get to use. And I think of, our program service classification that just went, public after 2 years of work. To me, that's a really meaningful case of, great, now the CIE gets to connect with Find Help, get to connect with Unitas, get to connect with Epic, get to connect with other service providers. And that's part of that larger implementation of interoperability. And I think, in all of this work, because we're all this kind of co-evolving and co-evolution, informs itself. And I think like one of the things I'm thinking about, and I'm grateful for the Highmark example, a really great presentation, and the power of let's really start placing value on the care coordination to service providers that are addressing social needs because we know that's where the major impact happens. And like, so for me, when I'm thinking about this work of how we puzzle piece everything together, there's these networked service providers, but those networked service providers are also doing care coordination with non-networked service providers.
Yeah.
How are we accounting for and not creating further silos in some of this work? But rather like all of our work fits together in as more channels are created, how does then those channels get to empower and inform? Great, let's connect all these other connected service providers as well. And not like kind of create these entrenched care coordination pathways that don't include all of the hubs. But I think that's where Gravity is so powerful because it creates the language that is relevant to every single space of care and not just funded work or non-funded work, but really like breaking down those silos of how do we actually just have our systems talk so we are able to do stuff together.
Love that, Lena. Lena's a partner in the trenches on a daily basis and like a lot of the work that we do. So thank you so much. Rachel.
Hello. Hi,
Hi.
everyone. I'm Rachel Eager. I am with Unitas. I've been a technical program manager at Unitas for a little over a year, but you may have seen my face pop up in other settings because I've
Hi.
been involved in interoperability and in Gravity Project for many of years. So I'm really excited to talk about this question because when I think about ROI, I'm really thinking about the providers, the community health workers, and other clinicians who are sitting in front of a patient and trying to build trust with that patient, and how we on the back end can care instead of having them care about like the data and making sure that their integrations are seamless so they're working for them. And that's how I think standards really come in because if those two products are speaking the same language, we're
Mhm.
able to do that for a provider. So, for the purposes of today's question, I wanted to highlight a few examples where we can talk a little bit about ED visits and reducing those in addition to reducing provider burdens. The first one I want to talk about very quickly is North Carolina's Healthy Opportunity Pilots, which I'm sure folks have heard about. And that actually addressed social needs such as food, housing, and toxic stress in North Carolina. So we did find that the Medicaid per member per month was we were able to see an $85 savings per member per month by addressing those specific outcomes. And then in another program with Ballard Health, where data really comes to be impactful because if you have standardized data through the Gravity Project, you're able to also see how needs are actually looked at. So, um, in 2020, the Virginia Department of Health invested in the creation of the Unite Virginia Network. So, and then in 2021, Ballard Health equipped a team of their community health workers with the Unitas platform to streamline referrals through the Unite Virginia Network. The impact on this, so we did a study from before the use of the Unitas platform and healthcare workers going out and um, addressing social needs and after, and we were able to see an 8.5 fewer hospital individuals visited the emergency department, a $835,000 estimated annual savings, and additionally $68 in monthly savings per patient. So when you think of also efficiencies, lowering emergency department visits, getting people the care that they need in the community, and being able to look at ROI, Gravity project standards are really important there.
That's so great. I didn't think there'd be so much like gravity love, but I guess I knew what I was getting into. So now I'm going to flip it. So anything, did any of the statements any of you all say, did any of you want to respond to that, or do you feel like we should move on to the next question? Are we good to move on? I think we want to just make sure, okay, we're doing okay on time. I see you, Demry. Okay, so we just had some really salient examples in Highmark on, actually cost savings and efficiency savings. And one of the things I loved about their presentation also were the metrics of sustainability, because we saw that the Gravity members prioritize these sustainable relationships to support community-based organizations over time. And we also talked about the payment reporting, discovery, and some things that might need to change. So this next question, I'm going to flip it. So Lena, I'm going to start with you, then go to Rachel, then go to Esther, and then end with Jaffer. So I'm going to flip it up. So what standards or standard methods need to be developed to increase efficiency, decrease burden, and increase savings? Noting that you all have highlighted a couple things already in the payment and reporting, HIC picks for social care services, just like coding for food, and then issues to try to support standards for social care claim reimbursement. So Lena, what needs to happen to build upon, like to expand on gravity standards and standard methods to increase efficiency, decrease burden, and increase savings in your mind?
Yeah, I'd say a couple things. One of the things that I mean is I've already talked about in other gravity meetings, but I think is part of the puzzle of understanding like the activity and work that's being done is to kind of take down some of the burden of receiving service providers. So CBOs that are receiving referrals from different entities, and it could be from healthcare or from other social care, equipping them with information about, hey, this person being connected to you, are they a meaningful and good fit so that I'm not bearing the administrative cost of kind of evaluating that referral. And so one of the things that I think is really a next step for Gravity Standards is, alongside how we describe what are services being provided, really being able to standardize data that speaks to who are these services for? Because that is that second door of access that really makes or breaks whether or not someone actually gets that service, but more than importantly, that someone is connected to a meaningful service that they're actually able to access, and that the service provider receiving that referral is not bearing all of the weight of essentially verification that it's an appropriate referral. And so how can we create data standards that really dive at eligibility of services and who they're able to be served? So I think that's a Gravity standard that is needs to be developed,
I
and
think,
will be
Elena, you might be proposing that.
a meaningful part of our interoperability work. And I think part of that is because we are often asking service providers to bear a really strong, kind of cost for, I'm only contracted to serve a very specific group of people. And in this kind of referral framework, the sending provider doesn't necessarily have that information, and or the technology doesn't necessarily support that. But I think that's where the content of Gravity Standards really could enable that.
I love that, Lena. I think it gets me to work with my fun classification crew over and over and over again forever. Count me in. Rachel, you're next. Trying to flip the order. And what do we need to do to the standards world to increase efficiency, decrease burden, increase savings?
So, something I am very excited about on the 2026 roadmap is safety terminology, because I think it aligns with a lot of the questions and out there, especially on the AHC-HRSN, and thinking about how that terminology can lead to better referrals. So, that is one of the things I am very excited about. I want to echo also what Alana was saying about improved eligibility standards, because I think there's a lot of information out there on eligibility and what that looks like, but how do we create more standardized approach to referring individuals to services? And then finally, I think the work on standardizing payment reimbursement and reporting requirements, especially with Medicaid changes in 2026 and what those look like, is going to continue to be very important.
Love it. I love that, of course, you know that the IPS expansion with those two domains is relevant to the AHC-HRSN. That's a lot of codes. Sorry.
Yeah.
We did some interpersonal safety concepts in prior years. We're completing our set, and that helps entities using the Accountable Health Committee's health-related social needs screening tool. Whew. Okay, Esther. Okay, what standards or standard methods need to be developed to increase efficiency, decrease burden, and increase savings? And then after you answer, Jaffer will take us home.
I definitely want to echo both Alana and Rachel. I think they hit it on the mark, right? There are standards that we need to be more consistent about across our eligibility, redundancies, to eliminate redundancies. We are faced, Rachel, with the CalAIM, with the Medi-Cal reform, Medicaid reform here in California. We're seeing the redundancies, right? Each health plan asking it differently, but for the same program, right? Then I think my ask or pitch would be, how do we get folks just aligned more, right? If it comes down to providing X service and that service does not change from this location to this location, from this health plan to this health plan, how do we then have the payers, I'm coming from that side as the CBO, how do we have the payers then not add that administrative burden when it comes to reporting, when it comes to billing, and all these redundancies and differences between what they require for, at the end of the day, the service is the service, the same service, right? I do get standards being maybe different when we're working on different lines of business, different populations, different programs, requiring different reporting. But when it comes down to similar like programs, especially in services, and this goes down to our network of providers as well, be it meals providers, be it, folks that help with DME and whatnot. how do we then not make it an administrative burden to circle back on those reportings and billing requirements?
Love it, Esther. You're echoing a very key finding in our payment in the member-led payment and reporting discovery, and something we're continuing to work on, like tangential to Gravity's efforts to make sure that we support CBOs and payers in that. Jaffer, can you close us out? And I know we are going to have very short office hours today, but we had a great conversation with members. Jaffer, take us home.
Wonderful, wonderful. So two, I think, really excellent ones. One would be every CBO has screening questions. Are you a veteran? What's your income bracket? Are you over the age of X? Do you live in these counties? And if we developed a standard library of these questions,
Oh,
think about how much time would be saved with that screener question being pre-populated by the data from Epic or Cerner or the
mhm.
EHR or the case management tool. Meaning, we're not going to send the person somewhere and then have them get a phone call and answer questions where we all already know the answers to those screening questions. So I've been talking with Epic a lot about this, and we all have these screening questions in our systems, and if we normalize that library, gosh, I think we'd make a big difference. And then the second is really getting to the other side of the mountaintop of referral routing, meaning whether we're referring into San Diego's CIE Salesforce instance or another closed loop referral system, as long as we're following the same webhook specification, we can make this bidirectional, and as long as consent is protecting the data the right way. Many of us do referral routing already, some of us don't. I think we've just got to get that done to eliminate this. Can I use whatever system I want in my community? And I think the caveat there is the federal government should decide, is there a minimum threshold to receive federal funding as a CBO? Meaning, do you have to have some sort of compliant and secure system, or can it just be a mom and pop technology platform? And that's going to require some debate. But those are the two, Sarah.
Thank you. I want to note there's a theme that we hear that there might be a need, Elena, for standard terminology to support connection to services that relate to features of people and regarding eligibility. Elena Kalinowski. Everyone agrees that might be necessary.
The road I've been marching down for the
I
last
know,
couple of
I know,
years.
I love it. Okay, next slide. I think we're done again. We're very, very close to time. And there's no time for community office hours, which is usually when Corey and I weigh in and answer questions. Esther, Jaffer, Elena, and Rachel, thank you for your membership. Amy, I know Highmark had to leave. Amy DM'd me. They're also members. We wanted to have this be a member-focused day, and it really was. And we're so grateful for your leadership and expertise. And now we have new ideas. There's things I had not heard before, Jaffer, about new things for us to do. This administrative questionnaire, Rachel, which that makes sense, I think, to you because we've been talking about similar things in New York. Demry, back to you to carry us home, and thank you so, so much.
Yeah, thank you. And I wanted to also follow up with that. And thank you so much to our member roundtable participants as well as Highmark. I know they left, but this was a really fruitful discussion. I'm really thankful for all the participation from the audience today. It's been really great, a great way to round out 2025. This is our last meeting of the year. So going into next year, and also, I think it is this afternoon, Sarah, correct me if I'm
In
wrong, but the
5 minutes.
terminology work stream right after this.
You know.
So be sure to tune in for that if you are interested. We have a lot of great calls coming up in our planning for 2026, which is wild to think about. But stay tuned. We will have more information on next year's Affinity Group meetings coming out in the near future. So stay tuned for that. You can view all of our upcoming meeting information here, and I will be posting these slides onto our Confluence page if you would like to refer back to them at any point. And then you can also contact Corinne if you have any questions, general gravity.
And I'm
But
going to do a final thank you to our member implementation partner, Civitas, for all your collaboration and support. Go team.
Thank you. That's right. Yeah, very grateful for the opportunity to help with the Gravity Affinity groups this year. So it's been awesome, and we're looking forward to a fantastic 2026. So let us know if you have any questions, you know where to find us, and we will all be in touch. And if you're going to the terminology meeting, we will see you shortly.
See you in minutes.
Thank you.
Bye.
Thank you,
Thanks,
everyone.
members.
Thank you
You guys are the
all.
best.